I welcome you all to my presentation today on lower limb arthroplasty in geriatric osteoporotic patients. I think most of you know me, particularly proud to have worked in Wrightington Hospital, birthplace of joint replacement surgery, presently proprietor and MD of Sathi Superspecialty Orthopaedic Center in Bangalore. So most of you know me, so I'll skip this slide. Coming to the subject matter of today, osteoporosis, we all know it's termed as a silent killer. Osteoporosis or porous bone is a devastating disease that robs its victims of the bone mass. A weaker bone is difficult to fix, as we all know, and not a good surface for implant fixation. Let's explore these fundamentals a bit further. What are the surgical challenges in this very common orthopedic condition? We know arthritis affects around 20 million people in India, particularly arthritis of the hip and the knee. Knee replacement, we know, is a quality of life improving procedure, globally accepted. Osteoporosis, unfortunately, is a neglected field. Some papers indicate 70 to 80% of osteoporosis is not treated despite a distal radial fracture or a hip fracture or spine fracture. We know recent publication which shows that 30 to 40% of arthroplasty patients have undiagnosed osteoporosis. And the recent publication also shows that totally replacement, revision knee surgery leads to increase in osteoporosis due to stress shielding due to the implant. And very interestingly, a recent paper showed that after knee replacement surgery, there's an increased mobility of the patient and there's increased neck of femur fracture in the first post-op year. So I think first post-op year, I think these patients should be definitely protected and some kind of osteoporotic cover should be given to these patients. We all know knee is a complex three-dimensional hinge. It's not only like a door opens, but also imagine our door also rotating, 360 degrees in that axis. So it makes the whole thing, challenging. The conceptual changes and the reasons for the failure. We know that we have moved away from the J-shaped kinematics of the knee to the trans-epicondylar axis, and ECOF introduced this trans-cylindrical axis. We had a fantastic debate in the last Meet the Masters course about whether we should use mechanical alignment for knee or adjusted mechanical alignment, or we have to use a kinematic alignment or adjusted kinematic alignment or a reverse kinematic alignment or a functional alignment, which is a new kid on the block. And we have a medial pivot designs which pivot around the MCL and lateral pivot designs. And TKR in a younger active obese patient is a challenging operation, the so-called the millennial patient. We know in elderly above 75, the knee cycles around 1 into 10 power of 6 cycles per year. But in 55 and younger, it is 7 times this. And hence the revision rate is around 2% per year in the younger. So in 5 years' time, 1 in 10 of these younger TKR patients need revision. We also know that there is around 3% failure in the first 2 years following knee replacement surgery if we don't get the stability right during surgery. And we know about knee replacement, probably started in 1973, the year of my birth, actually 48 years ago. And the present generation of implants and techniques and technology show that, it gives 98% implant survival at 10 years and 95% implant survival at 20 years. So the bar is set very, very high. So the Indian standard has always been to do a safe surgery and take our patients home. But I think we need to move away from those standards to our implants lasting in our patients for these 15, 20 years, which is real success. Just that our patients walked after surgery is no longer a proof of our success, but implant longevity is a proof of a successful procedure. We all know, this person, Dr. John Insall, father of knee replacement surgery. He had a famous quote, a knee replacement is a soft tissue operation with some bony cuts. Why did he say so? He said this because he understood the role of ligaments in 1973. And even now in 2022, we are debating the role of ligaments. We know the knee has 6 degrees of freedom, and we need 3 basic cuts to do a knee replacement: a tibial cut, femoral cut, and a patellar cut. And if you add the permutation combination, there is 215 ways in which a senior orthopedic surgeon can get a knee replacement wrong. What is the spin that adds to this complexity due to osteoporosis? We just understood that the knee is a complex 3-dimensional hinge. The alignment versus balance debate is still going on in 2022. Which alignment to use? Mechanical alignment, adjusted mechanical, kinematic alignment, adjusted kinematic, reverse kinematic, or the new kit functional is still being debated in 2022. Role of ligaments is not well understood, and eyeballing only gives a 2-dimensional solution to what is a 3-dimensional problem. And osteoporosis leads to poor fixation surface, increased periprosthetic fracture. And we know that, once it fractures, it's very, very difficult to fix these fractures because the screws and plates don't have a hold on these fractures. So what are the solutions to this, particular challenge? Proper preoperative evaluation and planning is a must. We know the famous dictum: if we fail to plan for surgery, we plan to fail during the surgery. And proper pre-op investigation is a must. When we do a knee replacement, a stemmed implant with cement should be used. Patience is a virtue here, and there's no role for uncemented TKRs in osteoporosis. Even in THR, there's really no role for uncemented THRs. Post-op, very, very important. I put in red, osteoporosis treatment is a must. We have to use calcium, vitamin D if there is deficiency. And there's increasing evidence to show the role of teriparatide in these patients. And also zoledronate, very cheap, but it increases BMD for a short time. But there is a significant jaw necrosis and atypical fractures with that. Denosumab, again, very promising. It's an antioclastic osteoclastic agent, and we got proof that the periprosthetic BMD increases up to 6 months in tibia and 12 months in femur. So, and not following evidence-based medicine can lead to, sort of a negligence in our practice. And we know in 2021, the average cost of litigation in India is around 5 crores per patient. So coming to some of the examples, this was a 66-year-old lady, 120 kg diabetic, operated by the top 2 arthroplasty surgeon of my state. Unfortunately, got infected. After 5 surgeries, the primary surgeon gave up. She was left with the excision arthroplasty, and hence she was bedridden. Her relatives came to me 2 years after this. She came with the picture on the right-hand side. The issues were morbidly obese, diabetes, repaired quadriceps rupture in one of the surgeries, osteoporosis, 5 failed surgeries, multiple scars. Last surgery, surgeon was not able to close the wound, so I'd asked plastic surgeon to bail him out with a gastrocnemius flap. So I knew that if I had need plastics in knee, I have got only one head of the gastrocnemius left. She needed a bariatric table, and she had a shortening of 1 inch, which I'm demonstrating there, and a bold anesthesia. So we aspirated, planned the revision in 2-stage. We grew E. coli, got an antibiogram, put an antibiotic loaded spacer. The inflammatory markers came normal in 8 weeks. Further aspiration was negative. Then we planned, combined orthoplastic work. Had to get clearance from all the senior guys. And it was a prolonged 4.5 to 5 hour surgery. And despite rectal snip, the quality of quadriceps was poor, so it had to be repaired there. So after many challenges, put a cemented stem with a metaphyseal only cementing. It's quite important because recently, there was a situation in Bangalore where, an infected case, a fully cemented stem was used. And unfortunately for this particular surgeon, the infection recurred in 4 weeks post surgery, and there's no way to remove the cemented stem. So they had to do osteotomy of both the tibia and femur and take it out, and unfortunately had to fuse the knee. This lady sort of walked 5.5 years following a bedridden state. That's what sort of gives us happiness. This is a case 2, a marked osteoporosis and pathological dislocation. So unfortunately, they were not rich enough, and they opted for a fusion. So knee replacement is not a solution for every condition. So we have to sometimes think out of the box. So I'll go to the case 3. This is, during my first year's exam, my examiners always told me, to pass you, Mr. Srikanth, you have to be safe to operate on my mother, not my mother-in-law, and they used to laugh. Very strangely, there's my mom's x-ray, and, I ended up operating on her a few years ago. I had a senior surgeon with me, and when I said, please start, sir, he said, Dr. Srikanth, you're senior enough, start. So spinal was already given. I had no other choice. After 5 minutes, I forgot that it was my mom, got on with it, got involved with it, and because of marked osteoporosis, I had to put a cemented stem. I sent this x-rays to my trainers in UK. They said, Sri, you're very bold. I would not have done it myself on my own mother. So this was quite a challenge, really. So since last year, I started robotics, and most systems have a navigation pin to be placed for trackers to be fit in. This was my last robotic. She had osteoporosis, and the DEXA confirmed it pre-op. During the femoral anterior pin placement, once the anterior cortex was through, once the pin touched the posterior cortex, I got a bleb in the anterior cortex and a crack around 5 millimeters. So, my heart stopped for a second. I put my finger around the femur, make sure that I had not caused a periprosthetic fracture even before I started surgery. I knew this was due to osteoporosis. You can see the X-ray here post-op, and I'm marking where the pin track led to a crack in the anterior cortex, which I filled in the end with bone from the shavings. This was the post-op, this one balancing. She had an excellent balance, 0 to 120 degrees knee flexion, 1 millimeter, as shown by the blocks on the pink and the orange. And post-op, I put her on teriparatide. To be cautious, I put her on partial weight bearing for 2 weeks and full weight bearing after that. She had a good recovery in around 8 weeks' time. She's got now 0 to 130 degrees range of movement. It was immediate post-op in the recovery when she was able to straight leg rise, and also she was able to bend the knee up to 90 degrees. So my take-home message is totally replacement in osteoporosis is like a complex primary. One needs to plan, and patience is crucial. We don't need to rush. Surgery is not about the race against time. We have to choose a cemented TKR with stems. We have to be gentle with the bone. No need to bash the implant. Beware of the impending periprosthetic fracture in that robotic case. We should not forget the basic. Cement is not a glue, but a grout. It's strong in compression, weak in shear and torsion. So these are fundamentals. And not if somebody is junior, please don't perform it on your own. Get some seniors to help you. Indian judiciary, I feel, is one of the most hostile environment, with 5 crore per case being the average compensation is 2021. When things go wrong, we get roasted and broke if this is a compensation, and also get jousted as well. There's a popular saying in UK: when there is a difficulty, refer to appropriate trained specialists. Or opt for a combined work. There's no ego when patient safety is concerned. Most seniors will help in India if we ask. So this is coming to hip, again, outcome for osteoporosis, 2 days post-op. Who wants this? So it's increasing evidence that, there's a big role for a cemented THR in elderly osteoporotic patients. The conclusion from 5 annual reports of international joint replacement registry and meta-analysis shows that cemented THR gives a good long-time survivor, 89% for 15 years compared to cemented at 86%. And the cemented THR survived better in older patients. Older patients with cementless fixation led to increased revision risk, particularly periprosthetic fracture on 30%, in females above 75. Such risk should be informed to the patients before surgery. And I feel that in 2022, there is no role for uncemented THRs in geriatric age group. We had a fantastic debate 2 years ago in Meet the Masters when Professor Hart from London said that 3D printed implant cemented stem is the best. So we need to get it right first time. So this is what Dr. John Howell said from Exeter about the benefits of a cemented THR. So these are the references for my talk. I thank you very much for the patient listening. I know I compressed a 40 minutes talk into 10 minutes, which was a challenge. So I put the whole talk on the YouTube. So kindly subscribe, like, and follow it on this link here. You can take a snapshot. So I welcome any questions if there are. Before.